Professional oral health during pregnancy continued. So it's important for us to take a really thorough medical history as always, document the medications that our patients are taking, including over-the-counter prescription, herbs, and supplements. And of course, we're not going to necessarily, just like with anything, any other patient, we won't necessarily know the details. So it's really nice to have things like the lexicon to be able to type in and see if there's any oral implications that a patient should know about. And then additionally, whether or not there's anything adverse during pregnancy. So in the fifth edition of Darby and Walsh, there's table 46.3, kind of highlights things that really pertain more specifically to like the dental care environment. But in general, patients should know whether or not they're taking something that could have an adverse effect on their pregnancy. And so if they write down a big list, it would be good to have that conversation. Like, have you shown this list to your OBGYN, and do they know that you're taking all of these and that they're safe for pregnancy? Or you could, pull up some of them and do a search with your patient to help them understand. So there used to be, up until recently, there was the categories A, B, C, D, and X. But recently in 2015, the U.S. Food and Drug Administration released its new pregnancy and lactation labeling rules. So as things sort of come to the information needs updating, they're going to change, and they're going to go from A, B, C, D, and X to a different system where they basically talk about its safety in a different format. So I didn't want to go into all those details because I'm not going to test you on that, but the labeling will appear differently for prescriptions and for over-the-counter supplements and herbs. So this slide is very, very wordy, but this is basically the table 46.3 for those of you who don't have the 5th edition. And sorry, it's a table in the textbook, it's in a table form, but I just wrote it out. So for example, for analgesics, acetaminophen with codeine, hydrocodone, and oxycodone, and morphine may be used during pregnancy. Obviously, we're not going to be giving those strong medications. That's going to be under the careful consideration of the doctor. Oral pain can often be managed with non-opioid medications. If opioids are used, prescribe the lowest dose for the shortest duration, usually less than 3 days, and avoid issuing refills to reduce risk of dependency. So there's all kinds of safety stipulations, and thankfully that's not in our scope of practice. But acetaminophen might be something that a patient writes down or asks you, I have this toothache, is it okay if I take acetaminophen and Tylenol? Aspirin, ibuprofen, and naproxen may be used in short durations during pregnancy, 48 to 72 hours. Avoid it in the first and the third trimester. So they're kind of in a window of safety in the second trimester, and they may be prescribed. Generally speaking, we probably would never do that, but an OBGYN may prescribe it during that window of that kind of safety window of the second trimester. And then here's antibiotics. Obviously, we don't ever do tetracycline because there's strong oral implications for the staining of the teeth. And then ciprofloxacin and these other antibiotics are avoided during pregnancy. And then amoxicillin and clindamycin, penicillin, those are more commonly used during pregnancy. Anesthetic, local anesthetic with epinephrine may be used during pregnancy. Nitrous oxide, up to 30%, may be used during pregnancy. When topical or local anesthetics are inadequate, pregnant women require lower levels of nitrous oxide to achieve sedation, and then consult a prenatal care health professional. And there's a little bit more on nitrous oxide later in this slide deck also. Barriers to care is a big issue. A lot of low-income women who are pregnant are going to have difficulty accessing regular prenatal care and regular dental care. So it's important for us to be familiar with these barriers to care. There's a variety of reasons why they might not have access to dental providers, depending on the state in which they reside. Women who are insured by Medicaid, and the Medicaid is that state and federally funded program for financial assistance designated to those who are unable to afford the health services. But those who are insured by Medicaid may or may not have dental benefits. So even if they have free obstetric care, they may have no dental care in provisions in the Medicaid insurance, and then they certainly wouldn't go unless they were going to have emergency, like an emergency toothache or something like that. Modification to the dental hygiene appointment. So it's important for us to understand their propensity to feeling tired and nauseous, especially in the first trimester and the beginning of the second trimester. It's important for us to always ensure when they come in that their head is well above their feet and that they're able to frequently change body positions if they need it. Just check in with them regularly. How you doing? You still comfortable? Is the weight of the baby bearing down on you and making you feel lightheaded or dizzy? So it's important for us just to talk to our patients, and we can put a small pillow under their left hip or their right hip to kind of have them turn a little bit to the left. If women turn to their left side, tend to relieve the feeling of that hypotension, that dizziness and nausea from the baby putting pressure on their vagus nerve. So dental radiographs during pregnancy. Radiographs are safe when the abdomen and the thyroid are shielded. However, it's up to the healthcare provider to follow a LARA. That's as low as reasonably achievable. We always want to do this with all of our patients all the time, but there's certain times when we really don't want to forget that we want to follow this this regimen. And so that would be using the fastest imaging receptors capable with the diagnostic task. So digital, most everybody's digital, or like the fastest fastest speed for the traditional films if you use traditional, but most everybody nowadays is on digital. The collimation of the beam to only cover the sensor, so it's not, radiating their whole head if we don't need to. Proper film exposure and processing techniques. We want to make sure we're doing our part, not to mess up and, oops, I deleted it on accident, or I processed your film wrong on accident. I guess I got to take the picture again. So we want to make sure that we're doing our job so that we're reducing our patient's risk. Use of proper protective apron and thyroid collar, limiting the number of images to only what's necessary. It's fine if we have to take 1 or 2 films. We probably won't take an FMX just because we want to see how things are looking. We want to locate it to just the areas that we're concerned about during that pregnancy. So this slide is also from my last slide deck from the years previous. So we said that the fetus is especially susceptible in the first trimester. So again, if they have to have an x-ray during the first trimester, it's fine, but we don't want to ever do anything elective or just because we wanted, you're due for your bite wings, let's take them, even though you're 8 weeks pregnant. So it's clinical judgment, and it's really just considering the pros and cons and the benefits of doing something. No radiographs exposed in the absence of clinical signs and symptoms. If diagnostic radiographs are required, we want to use the apron and thyroid collar. Pregnant dental personnel. So if you're pregnant, if you're the dental hygienist and you're pregnant, you can wear an apron when you expose radiographs. You can stand well behind the wall and 6 feet away. You can make sure that the direction of the tube head is going, the central beam is going completely in the opposite direction of you, either, side to side or back, but not coming straight out the room toward you. And then wear an exposure badge during your pregnancy if you want to check and monitor your exposure rate. When I was pregnant with my first daughter, I didn't wear a lead apron, but I stayed outside, and I wore a badge, and it never read above even remotely close to anything that was dangerous or harmful. So really the exposure is very, very minimal. But those are things you can do to feel more comfortable and to be reassured that you're staying safe. Pregnancy and nitrous oxide, so we mentioned this, it is considered safe. There's no FDA rating. There have been studies, again, this is from my previous slide deck. So the fourth edition did talk about the studies that demonstrated some increased dangers for prolonged exposure. So there have been studies that show that, like, dental assistants or dental hygienists or dentists, female, who have been exposed to a low dose over a long time, have had spontaneous abortions, increased birth defects, altered immune responses, increased congenital abnormalities. But that might just be isolated situations where they didn't have safety protocol in place. You know, like we always have our scavenger system. Things are checked regularly. You can have, something that checks for leaking of nitrous oxide into the environment. So if your office isn't doing these safety checks, then if you are pregnant, you might want to say, what are we doing to ensure that there's not a slow nitrous leak or something? Offices must maintain a scavenger system in good working order, and then the maximum exposure, 50 parts per million of the nitrous oxide in the air for no more than 8 hours per week. So if it was something, if you do use nitrous a lot in your office, it's something to talk to your doctor about the safety protocol. And then if you're not comfortable administering nitrous when you're pregnant, I personally didn't want to administer nitrous when I was pregnant, but that's a personal call. Now, giving your patient nitrous, they generally say a single low-dose exposure of no more than 30 minutes in the second or third trimester is considered perfectly safe. But as you could see in the 5th edition, it's saying during all times. Personally, I would always just consult the OBGYN. I would give them a quick call, no big deal. My patient is in this trimester and they're requesting nitrous. Is that all right? And just have a discussion with the other healthcare provider. Pregnancy and lactating mothers, 1 to 2% of maternal drug dose is excreted in the breast milk. So again, any medications that they're taking needs to be considered whether or not that's going to have some kind of an effect on the baby through the breast milk. Breastfeeding mothers should avoid aspirin, NSAIDs, tetracycline, Cipro, Flagyl, these other diazepine, because a little bit can be excreted and it could make your baby drowsy. Now, if the doctor's prescribing it for some specific reason, and you're curious as to what that is, you can always call the doctor's office and say, my patient came in today for a routine dental visit, and I noticed that they're taking X, Y, and Z, and I just wanted to know if that was considered safe, or what the reasons for prescribing that medication were, or you can have a conversation. It helps educate you, and you could potentially educate your another healthcare provider. Epinephrine is contraindicated with breastfeeding mothers. Now, this was not mentioned in the 5th edition, but this was in the 4th edition. It does say that epinephrine is excreted in the breast milk, so if it's necessary to use, just have the mother wait 9 hours to have it get through their system, they might pump out their breast milk after they had the epinephrine, and then but you can also, again, always utilize the other healthcare professions and find out if they think that that's something that needs to be avoided, or if they think that not enough epinephrine gets into the breast milk for it to matter. So these are conversations, especially since it really does seem like the jury is out, and overall the new information is saying it's safe. If it contradicts something that you read, then discuss that with the healthcare provider. Is just the safest route to go. Pregnancy and alcohol, obviously all alcoholic beverages or anything that contains alcohol is generally discourage or the patient is to avoid during pregnancy. Inquiries about drug use, alcohol use, tobacco habits, and counseling are usually on the medical history form, and you can talk to your patient about that if they need some information on who to talk to about tobacco cessation or other substance abuse. Fetal alcohol syndrome is a central nervous system damage. It's damage to the central nervous system and affects the baby's motor skills, skin and muscle innervation, and then behavioral aspects of their personality. And this is an image of that kind of classic fetal alcohol syndrome. We don't see a lot of this because women are very educated on the dangers of alcohol. It's very rare. Chances are you'd never have to bring this up to your patient, but it's important for us to understand that that danger with alcohol and pregnancy. And then lastly, most healthcare providers are not trained as integrated teams. So this is a new concept that we are educating more and more. And Pacific is wonderful about this interprofessional teams, but especially lacking in collaboration between medicine and dentistry is just barely starting to come together. There's so much wonderful work that could happen between the collaboration between dentistry and medicine, and it's exciting to be here, but it's really early. So interprofessional collaboration in dentistry is an emerging and long overdue practice because oral health is an integral part of overall health. And we've known this forever, we've preached this forever, but it's just now really resonating with the medicine, the general medicine. Another emerging healthcare trend relates to government policies that promote prevention and keeping people healthy rather than providing treatment. So of course, dental hygienists are all about prevention, but this is kind of a relatively new concept in our day and age that, hey, let's focus on prevention instead of treatment. And it's, far more economical. Patients are far more, there's less stress and suffering involved if we're preventing disease instead of treating disease. Although these later changes have not impacted dentistry as much as medicine, they are on the horizon to enhance health and patient experience and to decrease cost, also known as the triple aim. So this is a little schematic from the textbook, and this shows the triple aim: experience of care, health of a population, per capita cost. So if we focus on all three of those, we really have hit the target of how to really reduce costs, prevent disease, increase quality of life. Pregnancy is an ideal time for interprofessional collaboration because of the impact of pregnancy on a woman's oral health. Therefore, dental hygienists working with obstetricians, family medicine physicians, nurses, midwives is essential for optimal health for a pregnant woman. For example, there may be opportunities for a dental hygienist to teach or contribute to prenatal classes and educate in prenatal courses. I love that idea. I think that's amazing. A lot of these are offered by medical groups and practices, birthing centers, and hospitals. So you could collaborate with nurses and midwives who oftentimes teach these topics. Further, by working with pediatricians and family medicine, physicians, and additional collaboration can take place in preventing early childhood caries. So there really are wonderful roles for dental hygienists in this interprofessional collaboration. All right, that's that. See you guys in the next one.